Hello and welcome to the Becker's 11th annual meeting and our featured session, A Business Case for Centralization of TeleSitting, Clinical and Financial ROI at Ochsner Health. My name is Carly Ixagas, and on behalf of Becker's Healthcare, thank you so much for joining us today. Before we get started, I would like to first go over a few quick housekeeping instructions. You can submit any questions throughout today's session in the Q&A box on your dashboard. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's session to access that recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. Lastly, you'll also find a few other engagement tools on your dashboard. Be sure to check out our resources section and fill out our event survey. At this time, it is now my pleasure to begin today's program by introducing today's session moderator, Lisbeth Votruba, Chief Clinical Innovation Officer at AvaSure. Thank you so much for being here, Lisbeth. I'll now turn the floor over to you.
Thanks, Carly. Welcome. So the story the Ochsner team is going to tell today is about how a telehealth program can really epitomize the benefits of centralization at the system level. So the 17 different hospitals that participate in this telehealth program can point to really measurable financial and quality outcomes for being part of the centralized system program. And so before I turn it over to Jennifer and Rachelle to talk about it, I'm going to just provide a little bit of context, what telesitting is and what it isn't. So this slide here kind of compares telesitting on the right-hand side to traditional telehealth, which is episodic, what you think about where one provider interacts with one patient for a short episode, and it's sometimes in the patient's home, so direct to consumer. Whereas telesitting is a 1:16 ratio and up to 1:16, and it's usually in an inpatient setting. The focus is on patient safety and staff safety. I want to make sure I mention staff safety as well. And one trained monitor staff member is able to proactively keep multiple patients safe. And then the uptime is continuous 24/7. And the safety issues that we often see nurses selecting patients for this higher level of surveillance is if they're at high risk for falls or elopement, wandering out of the hospital, if they're low to moderate suicide risk, or if they're in danger or could potentially harm their staff members. And so they're preventing workplace violence events as well. And a picture's worth 1,000 words, so I just threw these in so you could kind of visualize how that works. So a device is in the patient room with 360 pan tilt zoom camera, really strong audio, two-way audio, microphone, and speakers, because that communication piece and that remote technician really becomes part of the care team and engages with the patient. And then on the right-hand side, you will see what kind of a centralized hub looks like with multiple staff members, each with their own patient assignment there. And Jennifer and Rachelle are going to talk about that role and what they're doing with that role and how it's become a stepping stone at Ochsner. So I think that's that. Just wanted to kind of set that groundwork and turn it over to you two. So Jennifer Humbert is the Assistant VP of Telemedicine, and Rachelle Longo is Assistant VP of Telemedicine Strategic Partnership Solutions. And welcome, and please just give us a little background on how you're set up there, how you're delivering telesitting there.
Excellent. So I will pick up and start. And part of the, we currently have our telesitter program, and we modeled our telesitter program and business model off of exactly what Lisbeth mentioned earlier, our hub and spoke model, and grew into this shift from the traditional episodic telehealth consults to the shift to what does it look like to have centralized bunker services. So we actually started our telehealth footprint here at Ochsner back in 2009. We started with traditional telestroke, and we continued to evolve our models. And in 2014, we took on our EICU model, which is the critical care centralized monitoring, where we have nurses that can care for 1 to 40 patients and physicians that care to up to 1 to 150 patients. And that quickly evolved into the opportunity we had in 2016 to then expand that to a TeleSitting program, which allows our sitters to be able to monitor. We right now are at a 1 to 12 ratio in our TeleSitter model. And our telehealth programs continue to evolve over the years since then. But truly, if we go back to those elements of that hub and spoke model, that's why Rachelle and I are together sitting here. Just as the basic foundational elements within the hub and spoke model and the success of telemedicine in the inpatient and in the hospital settings is that hub and spoke. That represents our work here. So my role is specifically is more of our internal approach, our product design, our implementation, our operations internally. But I can't do my job without my partner Rachelle at the table with me, and that's part of what makes our infrastructure so successful and has contributed to our success story over the years, and has allowed us to grow not only our telehealth network but specifically our telesitter network. We are now at 17 facilities. We have over 108 devices deployed and maintain that at a 24/7 operation. So I kind of represent that product and service side. And then there's also the entire solutions piece for our partners and represent the work that has to happen on both ends of that interaction.
Yeah, I think what makes us unique is that while Jen's team focuses on the solution itself from what we'll call the hub side, my team focuses on the partner who's receiving the service. And so those 17 sites, I have a designated team who works with that site on the service that they're receiving. And so we'll go out and do rounds. How is the service you're receiving? What are your needs? Are you receiving what you need? And so Jen and I, we complement each other very well, not just as people, but as services. And so she sort of serves as the hub piece, and I serve as the spoke piece of our business.
I found that to be kind of unique in the way you've set up your leadership. And I think it leads to success. That change management is just such a big component of a successful telehealth program. And so at the hub side, we've got Jennifer, but then out on those 17 different hospitals, and it's kind of a large region that you're covering there, you really need your nurses to select appropriate patients.
Absolutely. And so it's interesting. Honestly, change management is important on both ends, whether you're talking about at the hub side or the spoke side. But one of the things that we like to do is go into each facility with the outlook of what are you doing now for patients who are at risk for falls, and how do we take your current processes and evolve those, take our telesitter program and instill that and make the change, but not make them, I'm all about making people feel like they're choosing the process, and maybe not making them feel like they're changing, but my approach to change is making them feel like they're choosing the change. So but yeah, you're right. We are instilling change at the site location, but Jen can really speak to some change management that we've done, I think, within our own organization at the hub as well.
Before I switch over to have her talk about that, I think something that you said was, you asked, what are you doing now? And so I think what the current state or the traditional way of handling high-risk patients was to assign a one-to-one sitter staffing. and that in the literature has shown to actually not work and kind of takes away from the rest of the patients that are on the unit. But what did you do to get buy-in from frontline nurses to shift their thinking in their traditional practice from, oh, I'm just going to call staffing office and have them send up a body for me to sit 24/7 with one patient rather than using a virtual program?
I think some of the answers to that are twofold. Always, during the pandemic, I think we coined the term that said out of crisis comes intervention, and innovation, intervention and innovation, right? And so sometimes, it's twofold. So having that resource and that availability of somebody that's dependable to have in that room to take care of that patient, those resources are not readily available. So it creates a pain point for our partner sites, and it creates a pain point for the bedside staff. And so having that reliable resource or an opportunity to just be able to have the resource to do that solves a pain point for them, and that's a key. That's a key. But what you also have to do in creating of that solving of that pain point is also create a trusting and enduring relationship that resource is going to be credible. And I think that's where the other piece to that change management comes in is that we can be the reliable resource, just not a resource. And so ensuring that we have those ongoing relationships with our sites, ensuring that we are part of the falls committee, that we are part of the post-fall huddle, that we are part of all that data interaction supports that we didn't just fill a gap and now it's not necessarily with a warm body, but with a camera, that we replace that in a way that's reliable and improves outcomes and improves the quality. And just on that and that reliability of what we're able to provide and the service that we're able to provide. We had a patient recently that was admitted. It was a COVID patient. It was admitted for 30 days. This patient was on a camera for 30 days. Every day that patient was on that camera for 30 days, there was a stat alarm that was sounded at least 2 to 3 times per day. That's like, this was a truly, we needed high reliability. We needed good partnership with the bedside, but it was a 30-day stay. There were stat alarms that sounded 2 to 3 times a day, and that patient never fell. That patient remained safe and never fell. So the amount of, so if you think about that, and we tried to recreate that with reliable staffing at a 1-to-1 ratio every day with whoever you can kind of get that resource to go into that room. I don't believe that we would have had that same, I don't believe we would have had that same quality. It is allowing our teams to be experts together in that prevention and partnership.
That's a perfect example because, pre-vaccination, would you have wanted to assign a 1-to-1 sitter to that patient to be in the room with them 24/7 for 30 days? Is that even something as a leader you can feel ethically good about? And the alarm, so we were able to just publish in MedSurg Nursing in their March-April issue about telesitting on COVID patients. And the response time on the stat alarm pre-COVID is 16 seconds, but with a patient who's on isolation, it's 34 seconds because it takes apparently 18 seconds to throw on the PPE to get in there. So that is really something to celebrate, that your staff were able to not only respond to the alarm, but put the PPE on and respond to the alarm and keep that patient safe. So thank you for sharing that. I think what you're speaking to with the reliability is people, process, technology. It all has to kind of come together. So can you talk a little bit about how you make your telehealth technology decisions? What guiding principles Ochsner has?
Yeah, so it's truly our approach to, we truly have some founding elements. That's our approach to innovation. And we partner with our we partner with our IS teams deep, like we are attached. So there's the 2 of us, and then there's our IS partners, and we're all attached at the hip together. And our thought is from a telehealth perspective is that we truly look at what is our problem statement, what is our voice of the customer. We need this full voice of the customer feedback loop. We need to understand what the problem statement is, what those pain points are, and clearly identify that, and then stick to the strategy and the guiding principles around that, and allow those parts and pieces to inform the technology. So we truly allow, what's the pain point of the patient? What's the pain point of the provider? What problem are we trying to solve for? And what is that optimal state? What are our design principles around getting to that optimal state? And then we allow that, to back into our technology. As we partner with our IS team, then we have that upfront piece of work to do. And then our IS team has their guiding principles where, it is patient first. It's hearing us as their voice of the customer. And then they have, and then ensuring that, ensuring that the applications are safe, secure, compatible, data integrity. There's an entire process that goes through, but we're both aligned where patient first and pain points and designing up front and allowing and then backing into the technology comes in from that perspective.
Yeah, I should have mentioned that we are all nurses on the call today. So recently just had Nurses Week, and so let's keep celebrating that. Nurses 2020 was the year of the nurse and beyond. And so I also like it that a telehealth company like AvaSure values nurses on their executive team, board, and nurse educators, and sounds like same with Ochsner.
Yeah, and Lisbeth, my team that has the relationship with all of the sites who receive our services, they're all nurses. And so they're the ones who are out with having the relationship, in implementing the programs, doing quality improvement projects, those types of things with our partner sites.
Right.
And mine are staffed with nurses, yes.
You can speak to the evidence-based and point to peer-reviewed journal articles and speak the language. Yeah, that makes a lot of sense. So that's technology. And then on the people and processes side, just on our planning, we had some really great conversations around the staff that you have that actually provide the TeleSitting. So they're unlicensed. Some people just assume they're nurses, but it's actually an unlicensed position. So if you could talk a little bit about how you select staff and how that's evolved and how you train, because you've been doing this successfully for 5 years now. So I'm sure you have some learning to share with other people.
Yeah, and so we are evolving our staffing model, and what we're learning, and truly, so from our strategic priorities within Ochsner, we do have a strategic priority for hub and spoke model. We're always thinking about how we are commercializing our solutions in a way to best serve patients across the South. And, and just as I said before, our TeleSitter program, the dependency on high reliability in ensuring the expertise of the staff and how the technology works and how to care for the 12 patients at one time, and then how to do that in a way that's customer focused as well. And now we are also a service department. From a business model perspective, we're also a revenue generating department. So it's patient care, but we're also providing a service to our within our hub and spoke model, and we're also a revenue generating department. So what we're learning and the high reliability and the dependency of the staff in the bunker, I think as many people start out in a novice area of this and they're supporting their own system, they try to create that parity. We're just going to take our sitters and we're going to put them in a bunker and expect success. And what we have learned is that that's not necessarily the case, because you're right, we do need somebody that has patient safety at the forefront, but this is also somebody that needs to have a little bit more of a critical thinking approach. It is a larger patient load. It is very technology dependent, but then it is also a business model. It does, from our health systems perspective, create a business model and a customer service opportunity. And so what we're learning is that that's not just necessarily a one-for-one parity. We're just going to have we're just going to take our sitters and put them in So we have recently changed our staffing model a little bit. We're actually changing the job descriptions as well to represent that these are digital healthcare technicians and that they service our patients across the Gulf South as we continue to grow. And and like I had mentioned before, we have multiple types of services in our bunker. And so we're looking at ways to create synergy between the staff and the staffing models between a TeleSitter program, between our telemetry units, as we need virtual assessment coming in and triage, what are ways that we can leverage staff across the board, but still maintain that high reliability and expertise in quality and safety as well. So we have redesigned that staffing model and rethought about our structure as needing a little bit different level of support rather than just taking that parity traditional patient sitter from the floor.
So digital healthcare technician?
Yes.
I like that.
Yeah,
That's
it was extremely important for us. We looked across the industry. We're starting to see some shifts in like digital health techs but we truly felt having the word care technician to ensure that this role was around the care and the quality and the safety of the patient, and that patients are still at the center. It was very important for us to keep that in our terminology.
And I think it falls in line with Ochsner's initiative to really develop their employees. There's a lot of new education developments going on with their MAs. There's MA to LPN programs, LPN to RN programs. And I think this really just falls in line with a lot of the initiatives across our system to develop our employees to want to stay here in our own organization to take care of our patients.
And because these are the teams that are going to help us continue to innovate. Through COVID, we had a lot of new innovative workflows that came about. We did things a little bit differently. We load balanced our staffing differently. And, these are our teams that are going to continue, that approach to how we approach innovation. They're going to be our voice of the customer that helps us continue to evolve and optimize what we're doing virtually.
So it's an entry-level healthcare position, and it can be a stepping stone, it sounds like.
Absolutely.
To a career in healthcare.
Yep.
Wonderful. I think, something else you mentioned was revenue generating department. And so just on that, we talked about, I think the title of the session is about financial ROI. So I think it's pretty obvious if you can create some staffing efficiencies with virtual care, which is really a lot about what virtual care is about. So this time you're taking what would have been 12 individual sitters across the system monitoring 12 individual patients. Well, how many patients on a regular day do you have in the TeleSitter being watched in the TeleSitting hub?
We average anywhere from 90 to 108 patients a day. That we're able to monitor. We have 108 cameras deployed, but we fluctuate on and off somewhere between that 90 to 108 patients every day.
So instead of having 108 sitters in 108 patient rooms across the 17 hospitals, you have probably 8 or 9 telesitters monitoring those 108. Yep. So that's,
if you think about it,
the easy, yeah, go ahead.
2 cameras, some make 12 or 15 cameras. So the ability to really offset the cost is helpful. Big facilities and the small facilities, for somebody or even somebody who has 1 camera.
Right.
Yeah, I'm using 1 camera, but I'm using 1/12 of the cost that I was using before. So when you do it across your own system, it's very helpful, but then the ability to also help other organizations outside of our own is also better.
it becomes a very easy pitch and sale to some of our to our partner sites because the ROI is so clear. We've been like from our perspective internally within the system, we see about a 90% cost reduction when we effectively use our telesitters. And we've even expanded our staffing model in the sense that, you do the quick math. Yeah, we can run, you can run on about, 8 to 9 staff members. We've staffed that up. What we've noticed is that when you need to have, these are patients under constant surveillance. And so when we're working individuals 12-hour shifts, they need breaks. They need, there is screen fatigue that happens. So we've actually added a staff member to be pulled out just for breaks, because when you break, then somebody has to cover those patients that are constantly being surveyed. And even adding that layer, there is, we've that has barely even dented what our ROI or what our return is, or that 90% reduction in cost across the system. We're still able to achieve that, even with adding that layer of what we're calling a break person.
And then as they start to do this cross training between their telemetry, their centralized telemetry, and their telesitter group, it's exponential.
Right. So then you start to even see the efficiencies between those two areas.
That totally makes sense, and is so much easier to do on a centralized hub model. So if, like you said, you have some hospitals that maybe only use 1 or 2 sitters per day, and maybe they use none for a long time, and then it's the full moon and they need 3, or even 10 or 12. It's just a lot more efficient to just, like you said, add 1 staff member for break coverage, and you're able to kind of fold that in. And so, and if I'm understanding right, it is also a revenue stream for your virtual health center. That is awesome. And then switching to the quality side, and there's cost avoidance there. I'm just thinking about your COVID patient that was at risk for falling multiple times every day for 30 days. And one fall costs, $1,500, and a fall with injury even more if you have to get a CAT scan to find out what happened. So I don't know if you want to talk about if you're measuring, or if it's just that that these adverse events are avoided, or how do you measure that, or how do you talk about that?
Yeah, so we measure, we measure our financial outcomes within cost reduction and ROI, but then we also measure, we do measure our fall rates. So we benchmark internally, we do benchmark ourselves against what our system fall rates are, and then what our what we call our telesitter fall rate, and the differences between our system fall rate and our telesitter fall rate. And then what we will do is we will do a deep dive down into, if a patient was on camera, and they fell, what was the reason for that fall? And we will, and it will do a deep investigation into that. Fortunately, our telesitter fall rate is almost non-existent compared to our system fall rate, which is a clear indication on a good ROI. And we're actually starting to, what we've also noticed across the system is that part of fall prevention is also part of falls is also falls prevention. And so one of the things that we're taking on as an initiative to measure also is our telesitter team across our system leading post-fall huddles. So what you find many times is that at your large centers where you have resources, those post-fall huddles happen. In the community setting, sometimes it doesn't infiltrate the community setting as well, and we don't get that standardization across our system. So we can play that system role in ensuring that we have standard practices in post-fall huddle, and that we're aggregately looking at all of our data and all of the reasons for falls to make us to make us even stronger and better, rather than just our larger hub campus.
And then the manager from the telesitter bunker plus the team member on my team who is over the sitter service line actually both sit on the the committee for falls at each of the campuses. So we're helping each of the campuses on their falls committees. We're monitoring that from every aspect with the campuses. And so they feel as though this is a joint effort. We don't just put the camera there and say, okay, we're gonna have somebody watching your patients. We're also there as your partner to help you. So.
And that goes right back to that change management piece. Those
Yeah.
post-fall huddles across the system,
Yep.
without Rachelle's team out at all of those campuses, it would not be happening. We would have a great idea and we'd be like, hey, jump on our bandwagon, and that would not happen. So that's
a continuous follow-up. As a matter of fact, the nurse from my team, Monica, and the manager from her team were just making rounds in the Bayou region earlier this week. They got in the car together. They went and made rounds at all of the hospitals in our Bayou region. And so it's that partnership piece. They're constantly, it's not just a hub and spoke model. It's all about the relationship as well. It really, really makes a difference.
I'm so happy that we're doing this, because I think that's a real key, a best practice when you're implementing a hub and spoke model. And you apologize for it a little bit, Rachelle. You're like, I hate to say it, I'm kind of marketing, but you shouldn't hate to say that. I mean, that's what really helps make it work.
It's what makes us very successful. We're kind of that like in your face partner, but not too much. It's like we're there to let you know that we're always there when you need us.
That's great. And before we move off falls, and I just want to kind of put a plug in for workplace violence prevention across all of the hospitals that have implemented telesitting in our database. The percentage that are being monitored for falls is always like 60%, like the majority, falls is the main thing. And it's always 1% or less that are being monitored for staff safety. And so as a nurse, and I just want to kind of implore people to think about how to actually use technology for staff safety as well. So in emergency department settings where there's substance use withdrawal going on, or patients are impulsive and volatile for any reason, we do see that it can be very effective for that too. And it's really underreported. So I'm hoping that will increase as well. But so it's, and just elopement or pulling off, and with COVID, we see a lot too of helping patients remember to maintain their oxygen if they've got high flow or something like that. Just kind of monitor techs are getting a little more savvy and getting a little bit of training about respiratory distress as well. So there's just so many ways on the quality side. I just wanted to make sure we covered. But
we actually felt the effects of that during COVID. We had like many, we were an epicenter in New Orleans there for a while. We had what started to happen just in general and from a telehealth perspective is we had areas that had no volume in their hospital, some areas that had like no volume at all, and then areas that were just our New Orleans area that it was just overloaded, and we were able to help load balance some of that staffing in different ways from our telesitter bunker. And many times they would put patients on cameras specifically to just watch for respiratory distress. And so it wasn't that they were on falls, it wasn't for any other reason other than our team actively participated and was able to watch for respiratory distress and then escalate to the rapid response teams or call the bedside teams if there was intervention that needed to happen in those patient rooms. And also led then, as we were overstaffed in some areas and understaffed in others, they were able to send us staff to our bunker to be able to support those types of efforts where we were getting overloaded.
Like the definition of agile. That's great. Yeah. So just to wrap up, maybe both of you could weigh in a little bit about what you see in the future. And Go ahead with telehealth.
Yeah, so it's interesting, and I think our future goes well beyond just thinking about the way that we service our patients in our bunkers. And so, you know, like all other all other health systems from a telehealth perspective, we saw a massive increase in volume. You know, our direct to consumer visits, you know, went from a very low volume to like over 300,000 in a very short period of time. We also saw that same level because we were that epicenter. We saw that same level of provider to provider and virtual hospital services, and our bunker areas and our volumes increase. And so, you know, we saw this. If you think about Gartner's technology hype cycle, we saw this drastic increase in this uptake in technology, and we had all these new, and everybody went from a novice to an expert in telehealth because out of crisis came this need to have to use. And so we're really trying, you know, what we're doing is, you know, everybody's in that plateau. Like, are we going to revert back, or are we going to stay like at this level where we just continue to innovate, find new ways to use the tools that we have? And that's really where I see us going. And it's going to be a lot more about ensuring that we're linking the patient journey map through our digital interactions consistently across the board. So if we have a virtual or digital experience and we're able to provide family support, we're able to provide telesitting support, I'm able to send, you know, Rachelle home, and I say, my team's watching we're watching you from that, from a telesitter, she's not going to fall, but also then we can like bring you into that room and you can have an interaction with her later on that evening. If we need to have a consult with those providers, like we're starting to get synergies between all of our areas and ensure that our virtual experiences are consistently optimized across all spectrums of care. And we're making that experience consistent for our patients, our providers, and our partners. And as we continue to get new innovative partners, I think there's been a lot of talk in the telehealth world about digital front doors. I think the telehealth space, the healthcare space has kind of always thought about that digital front door as like, I'm literally going to walk through one way of a front door. I'm like, and it's really going to challenge us to be like, we're going to take the front door, the side door, the garage door. We're going to create consistent experiences, but we're going to build our strength on where our epicenter is in the services that we provide, and how are we going to get any type of partner or patient or consumer to that space.
What did you call that? A patient story journey? What?
The patient journey map.
Patient journey map.
Yes.
I like that. Okay.
Yes, if you think about it, we're really under this concept of we never admit or discharge a patient, right? So what's their journey map? Yeah. And how do we keep those experiences consistent? And what's happening in our, the bunker or our centralized staffing models? How are we creating synergies in those workflows with all of the other virtual experiences that we can offer? Will become key and vital.
Wonderful. And I agree. It's that hype cycle has been just accelerated, and it's an exciting time for healthcare, and we need to do everything we can to support the bedside caregivers, nurses. People talk about the heroes, you know, but I'm sad that the circumstances were there that required heroic efforts, and I just hope that we're able to provide the tools and technology they need to feel safe at work and keep their patients safe at work too. So thank you both for joining us today. Very informative, and you are doing it so well. So I hope that others can learn from you so they don't have to learn from their own mistakes, you know, and build it from there. So it's very generous of you to share your time with all of us today. Thank you.
Thanks for having us.
And that is all the time we have for today. I want to thank our Ochsner presenters for taking the time today to share these insights. And I also want to thank AvaSure for sponsoring today's featured session. And to our attendees, make sure you check out our other sessions and let us know if you have any questions, comments, or feedback. Have a fantastic day.